Hello and welcome to my YouTube channel. Today we will be talking about a very important clinical condition which can present as an emergency, and that is acute mesenteric ischemia leading to bowel wall ischemia and necrosis of the bowel and its further complications. Now, why this condition is important, we'll discuss, and we will be focusing mainly in this video about how to diagnose clinically where high index of suspicion is required. Number two, what are the important CT findings in a patient of a bowel wall ischemia, and finally a word about management. So it's a very high focused video on this very important surgical emergency which requires a careful evaluation and emergent management. It's a surgical emergency and so it should be treated accordingly. So before we start, let's recap the arterial anatomy of the small and the large bowel. Now, if you see here in this the superior mesenteric artery, which mainly supplies the right side and the transverse colon, it divides after rising from the aorta. It divides into three main important branches, and that is the ileocolic artery, the right colic artery, and the middle colic artery. So these are the three important branches of superior mesenteric artery, and this forms an arterial arcade right up to the two-thirds of the transverse colon. Now, lateral one-third of the transverse colon and descending colon and the sigmoid as well as the rectum is supplied by the inferior mesenteric artery. Now, this inferior mesenteric artery divides it into three important branches, and that is the left colic artery, which supplies basically the descending colon. Then we have the sigmoid artery, which supplies the sigmoid colon, and then we have the superior rectal artery supplying the major part of the rectum. So this is the distribution of superior mesenteric and the distribution of inferior mesenteric artery, which together forms a very rich anastomotic network in the mesentery and leading to a vast collateral circulation. However, two important areas, that is the hepatic flexure and the splenic flexure, remains one of the watershed areas where they are more vulnerable to any ischemic damage. So whenever there is an occlusion of one of these important vessels or its branches, the hepatic flexure and the splenic flexure is the one which is most vulnerable for ischemic damage to the bowel. Now, the clinical dilemma and pathophysiology of acute mesenteric ischemia. Now, as I've already mentioned, this is one condition which can easily be missed in a patient. And because these patients are, most of them are elderly patients who present this problem, a high index of suspicion is required in any patient who comes to the emergency department with a complaint of abdominal pain, which is out of proportion to the examination findings. That is one of the classical presentation. A patient may have severe pain abdomen, appears in discomfort, but when you examine the abdomen, at least in the initial stages, there may not be any physical signs to justify that. So in such case, if you're not very careful, this diagnosis can be missed. And because it gives you a very short period of time, that is 6 hours, the patient can quickly go into transmural gangrene of the bowel wall, leading to further complications. So this pain out of proportion to physical examination, the classic presentation where the physical findings are completely normal initially in the disease, but visceral pain, the pain experienced by the patient, is quite excruciating. That is one of the earliest symptoms which should make you suspicious that this patient may be having acute mesenteric ischemia. Now, mucosal to transmural ischemia. Generally, ischemia starts from the highly metabolic mucosa. So first thing, the first layer of the gut which is vulnerable is initially the mucosa. And if there is only a mucosal ischemia in the early stage, the stage is still reversible. But this, if the occlusion is not relieved, it can progress to transmural necrosis, and then it becomes an irreversible infarction. As shown in this diagram, within 15 minutes of an absolute ischemia, the structural changes to intestinal villi starts to occur. Within 3 hours of absolute ischemia, the mucosa undergoes ischemia leading to mucosal sloughing. It is still reversible at this stage in the first 3 hours. But as the time gap progresses and the level of occlusion remains for another 3 hours, totaling about 6 hours post occlusion, This can lead to then transmural necrosis, gangrene of the bowel, and ultimately perforation of the gut, leading to perforation peritonitis. And in this situation, the signs of typical peritonitis would appear with diffuse abdominal pain, diffuse guarding and rigidity, rebound tenderness. The patient appears ill. There would be tachycardia, tachypnea with a lot of electrolyte and metabolic disturbances. So here the time is crucial, and that's why this initial symptom, the pain out of proportion to examination, should always be remembered, and a high index of suspicion should be kept in mind for diagnosing this condition. Overdiagnosis is always better than missing the diagnosis at all. So the diagnostic trap here is waiting for the classical signs of peritonitis to appear. We have already seen means that bowel is already necrotic and perforated. So if we wait for peritonitis, or if a patient who you suspect has got acute mesenteric ischemia but shows a diffuse peritonitis, then the timing is already delayed. That means the bowel is already necrotic. There's already a perforation which has occurred, and the bowel may be totally gangrenous and insalvageable. In such cases, you only have to do excision of the bowel. That's why early intervention preserves the bowel length when the ischemia has just affected the mucosa, which is still reversible. Now, what are the early warning signs and certain biomarkers which would help you in making an informed diagnosis? Just remember that hyperperistalsis to ileus. So early on, the in acute mesenteric ischemia, the bowel tries to empty itself forcefully. So it would increase the force as well as frequency of the peristaltic wave. So when you examine the patient in such a stage, there may be increased bowel sounds. The force of the bowel sounds, the frequency of bowel sounds would be increased. And this would also lead to diarrhea, vomiting, and other things. But as the ischemia progresses over a period of time, and when it progresses beyond mucosa and becomes transmural, then the peristalsis ceases because of the ischemia of the neural plexuses also. And when the peristalsis ceases, the abdomen becomes absolutely silent. So this hyperperistalsis to ileus is a very important initial warning signs for disease progression. Of course, there are certain biomarkers also, biochemical markers. Metabolic acidosis, unexplained high anion gap metabolic acidosis in such a patient is also very suspicious. Serum lactate level, a very vital marker, but understand that a normal lactate does not rule out early ischemia. So just relying on serum lactate would be not be correct, because it may be normal in early ischemia, but by the time the lactate is profoundly elevated beyond 2 or beyond 4 millimoles per liter, the bowel is already completely necrotic. So just to recap, bowel sounds initially early or compensated stage, it may be hyperactive or even borborygmy, that means forceful peristalsis. But in the late or an irreversible decompensated stage, the abdomen may be totally absent, what we call silent abdomen. If we come to the lactate and pH, in early stage, lactate may be normal and pH may also be normal, whereas in late or in irreversible or decompensated stage, there is a severe lactate in elevation beyond 4 millimoles per liter, and their patient may also have metabolic acidosis. On abdominal examination in the early stage, the abdomen may be soft, non-tender, minimally tender. Remember that dictum, pain out of proportion. So abdominal signs may totally be absent. Whereas in late or decompensated stage, when there's already a necrotic bowel, perforation has already occurred, the abdomen may have signs of typical peritonitis like diffuse tenderness, diffuse rigidity and guarding, and rebound tenderness. Now, CT plays a very important role. A contrast CT plays a very important role in diagnosing a patient suspected of acute mesenteric ischemia. Once you have a patient with a high index of suspicion and you have done all your biochemical markers, patient should be subjected to immediate contrast enhanced CT, provided the patient is stable enough to undergo CT scan, and also the patient's renal function test is within normal limits. The key radiological findings on CT abdomen in a patient of acute mesenteric ischemia is basically the signs of the bowel ischemia or bowel necrosis. So the first one, which suggests that there is ischemia of the bowel, is pneumatosis intestinalis. That means the gas bubbles are trapped directly inside the bowel wall. This basically represents that the mucosal barrier is not totally gone and the intraluminal gas has seeped into the bowel wall. This pneumatosis intestinalis, as seen in this CT, the gas bubble seen within the wall of the bowel wall, is one of the surest signs of bowel ischemia, at least in initial stages when the mucosal barrier is broken. And whenever the pneumatosis intestinalis or gas is seen within the wall of the gut on contrast CT, this should specifically points towards ischemia of the gut. The second important sign on CT scan would be presence of portal venous gas. The gas which has migrated now from the bowel wall through the mesenteric veins into the portal venous system. Now, this indicates a very ominous sign. That means the disease is already gone beyond the gut wall, and the recovery would be delayed, and patient you can expect much more mortality, morbidity, as well as increasing chances of mortality. So, presence of portal venous gas, as again shown in this diagram as CT scan, indicates that there is a transmural infarction with the gas entering into the through the mesenteric veins into the portal venous system. And third very important finding on CT scan of bowel ischemia is bowel wall thickening, where because there is that may be initial sign when there is a congestion of the mucosa and the thickening of the bowel wall, which indicates that there is a impending ischemia which is developing and which is progressing. But a completely paper thin wall indicates absolute loss of arterial flow. So bowel wall thickening versus paper thin wall, this should be kept into mind. Now, word about surgical management and damage control. Once a patient is diagnosed, both clinically as well as on CT scan, immediate resection, immediate exploratory laparotomy should be done after resuscitation of the patient under broad spectrum antibiotics, and resection of frankly gangrenous bowel should be done immediately. Excise vigorously, aggressively until you see viable bleeding edges and active peristalsis. Take chances and excise a short of them to preserve the bowel, because you don't want to do again a relook or a refashion the edges again in the second surgery, which may not be well tolerated by the already poor patient who is already in a poor general condition. The second look strategy should always be kept in mind. If a long segment of the bowel is borderline or questionably viable, that means the edges are already necrotic or congested, there is absence of bleeding, there is absence of peristalsis, do not perform an primary anastomosis after excision. Leave the abdomen open with a temporary closure and re-explore after 24 to 48 hours. If there is an increasing ischemia, it may have progressed beyond your excised edges, and then you can do a definitive surgery. This prevents short gut syndrome by preserving marginally ischemic tissue that may recover after your 2 days of resuscitation. So this second look strategy, initial excision, leaving the abdomen open and relooking and revisiting after 24 to 48 hours to look the final line of demarcation between the viable and a non-viable gut, would take into account preserving the unnecessary excision of a bowel and leading to short gut syndrome. Now, once this is done, embolectomy or a bypass surgery, that means locating the site of occlusion in the major vessels or one of its branches, either in the superior mesenteric or in the inferior mesenteric artery, and immediate surgical embolectomy should be done and should take precedence over simple resection. So these are the important things which should be taken into consideration when you're managing a case of acute mesenteric ischemia. Embolectomy or bypass would always, if it is in the initial stages, that means only a mucosal ischemia, it can still preserve the viability of the gut. However, if there is obvious necrosis and transmural infarction and gangrene of the bowel, then excision of the segment of bowel, sometimes relook surgery after 24 to 48 hours, or creation of a stoma would help to save the patient, and later on a restoration of bowel continuity may be performed after 3 to 6 months. So this is in a nutshell about a focused video focusing specifically on the diagnosis, keeping a high index of suspicion for diagnosing a case of acute mesenteric ischemia, and what are the CT signs, as well as a word about the surgical management and damage control surgery in acute mesenteric ischemia. I hope you have found this video useful. If you have liked my videos, or if you're liking my content, please like it, subscribe it, and share it with your colleagues. Thank you for watching, and thank you for your time.